And one more. Fantastic. All right, we got everybody on screen. So welcome back, everyone else. If you're new, if you're just joining now, I'm Chris Llorente, IPS program specialist and IPS trainer for Alameda County Behavioral Health, and I will be moderating our last panel discussion of the day here, talking about IPS and specialty populations. If you were able to catch Dr. Gary Bond's presentation this morning, he told you all about, the years and the decades behind IPS and the research and how it was originally rolled out specifically for the specialty mental health population. But over the years, when you look at IPS, you look at the practice principles, we're talking about, competitive employment being the goal, systematic job development happening, we're at rapid job search, integration of services, benefits planning, zero exclusion philosophies, unlimited time supports, and adhering to worker preferences. When you think about all those pillars of this model, what specialty population could not benefit from this approach to supported employment? So over the years, it's gone viral. Excuse the pun, but it has expanded to other populations. SUD populations, veterans with traumatic brain injuries, the IDD population, so on and so forth. But today we've got 3 panelists joining us, and their populations are specifically around the CalWORKs and the TANF program, folks who are experiencing homelessness or have housing insecurities, and also our transition age youth programs. So with that, why don't I turn it over to you all. I want you guys kind of just go around, introduce yourselves, who you are, what agency you're from, and the specialty population. And then we'll just jump into some questions that I have here. And we'll just do sort of like a round robin, approach to things, and we'll see where the conversation takes us. Why don't we start with you, Christine?
Great. So my name is Christine Haworth. I'm an occupational therapist and the vocational services manager at OTTP in San Francisco. So that stands for Occupational Therapy Training Program in San Francisco. And we have an IPS program at our agency that is working specifically with transitional aged youth. So we work with ages 15 to 24. And we are part of a DOR co-op, which is pretty exciting. And all of the staff on our program are OTs, so that's pretty unique as well.
Thanks so much for having me. My name is Dara Weinger. My pronouns are she, her, and I'm a senior program manager at Corporation for Supportive Housing. CSH is a national nonprofit organization, and we do everything we can to advance the initiatives and the expansion of supportive housing, and that's across the states. We do that. And supportive housing, for those who may not know, is deeply affordable housing that's usually paired with subsidies and with services. I've been in the homeless services sector. I'm based in Los Angeles for 15 years. And my portfolio at CSH, some of the things that we do to advance advanced supportive housing is policy reform at all levels of government, training and technical assistance, and even lending. We'll provide loans to nonprofit developers who are wanting to build supportive housing. And so my background is in homeless services with a specialty in employment services. And my portfolio at CSH really is around bringing workforce development into supportive housing. And so I'm really excited to share about some of the IPS specific work that we've been doing.
Awesome, thank you, Dara. And last but not least, Tatevik.
Good afternoon, everybody. My name is Dr. Tatevik Abaryan. I'm a supervising psychologist with the Los Angeles County Department of Mental Health's CalWORKs Programs Administration. And so we work with the TANF or CalWORKs population, and within LA County DMH, we have a network of 52 providers who have the IPS program that we've implemented in. And so I think that answers all of the questions. So I'll hand it back over to you, Chris.
Very good. Thank you. All right. So just a reminder to all of our attendees, if you have specific questions that you want to pose to our panelists here, please do put those into the Q&A. And okay, so why don't we just jump into the first question? This is kind of dovetailing off your introduction, but could you tell us a little bit more about your IPS program in your community, in your agency? Tell us more just about the more specifics about the target population, how long the IPS program has been in existence, and any challenges or successes or outcomes you want to share with us. And go just jump on in.
Okay, so I guess jumped the gun a little bit earlier. We are an agency that has within our IPS model program, we have exclusively occupational therapists working on that program. And we're working, it's a community-based mental health agency to begin with. And so we are very used to the community-based approach of IPS. So it was a really great fit. And we started our IPS program in 2016. Like I said, it's for 15 to 24-year-olds who are referred by their clinician. So they have to have a mental health diagnosis in order to be referred. And then the only other requirement is that they are interested in getting a job. And so that's kind of the broad strokes of what it looks like to get involved in our program. We also primarily focus on young people who are coming through the BHS system, Behavioral Health Services system. So they all have, they're either connected to a non-public school because of their mental health needs, or they are receiving Medi-Cal. And so those are the two ways that they can qualify in that sense. Challenges, we've had a number of challenges, just like you would imagine. I think I'm sure we'll talk about this a bit more, but one of the big things with young people specifically is that they're at this point where they're deciding what path to take. And so it's not just getting a job, but it's also developing a career and figuring out what you're interested in and what you want your life to look like. And so with that comes a lot of work supporting that process, right? And so I think one of the things that we've discovered kind of organically, but has also been supported by the recent research out of WPS, not WPS, Westat. It's not Westat anymore. I don't know. What is it called now?
It's Columbia now, and it's still Westat, a little kind of,
The IPS folks. The research coming out of there indicating that there's really a need to simultaneously support young people with their post-secondary education goals as well as their employment goals, because they kind of go hand in hand in terms of figuring out next steps for a career. So I think that's been one of our challenges, how to figure out how to fund that and staff that and support that process.
Thank you, Christine. And so for generally speaking, for a lot of mental health programs, having an OT on staff is kind of like, having a unicorn on staff. There's just not many of you around. Can you talk a little bit specifically about, what the OTs, bring to, how the synergy between, the work that OTs do, the IPS, philosophy, and then I've got another question for you.
Yeah, thanks for asking that. We are really lucky in that the agency is very heavily staffed by OTs. So it's this lovely community of mental health OTs. And a lot of us don't, a lot of just the general population doesn't have access to mental health OTs, like you were saying. So you might be familiar with OT in a hospital setting or something like that. But what we do in the mental health setting is really focused on skill building and identifying barriers and helping young people, well, people in general, but specifically for our program, young people, develop the skills to overcome those barriers. And so in the application to the IPS model, it's great because we're able to identify coping skills that the young people can utilize while on the job, or we can identify environmental barriers that might be impacting their performance, and really work on helping to support them in this transition to employment. I hope that answered your question.
Yes, it does. And then during your initial introduction, you had briefly mentioned the DOR and the co-op.
Mm-hmm.
Can you tell us just a little bit more about that?
Yeah, so we're one of 5 or 6 agencies in the mental health co-op, the vocational co-op through. It's a collaboration of DOR, Department of Rehabilitation, with BHS, Behavioral Health Services, in San Francisco. And what's great is we're able to kind of share referrals. So we have a specialty age group, so it's a little bit different for us, but referrals that will just go into the Department of Rehab will be shared amongst the group. We have monthly meetings to kind of support one another and how to provide best services and really meet the needs of the folks in San Francisco.
And you guys still have your dedicated VR counselor?
We do. Oh, that's a good
single point of contact, which is fantastic, right?
It is pretty fantastic. I forget how wonderful it is. Yes, we have a vocational counselor, so a DOR counselor who is, we have phone calls with him every week and we text him when we need something extra. He's just really wonderful. And outside of that, we also have access to benefits planning because of the DOR co-op. It's wonderful because then also we're able to help our young people get the clothing that they need for their job. Oftentimes they're paying for things like CPR training if the client is interested in a job that requires CPR training, those types of things. It's really a wonderful collaboration.
Awesome. Thank you, Christine. All right, let me read the question again, Dara and Tatevik. So tell us about the IPS program you have in your community, the target population, time and existence, challenges, successes, and outcomes. Whoever wants to jump in.
I could go next. So again, our target population is the TANF or CalWORKs population, and in LA County, CalWORKs Programs Administration introduced IPS to our network of CalWORKs providers back in 2012. And so we've been implementing IPS on an ongoing basis since then. So our population is all adults. What's unique about the CalWORKs population is that not all of the clients meet criteria for serious and persistent mental illness. And so their diagnosis, their symptoms, their level of functioning is one of the things that does set the CalWORKs population apart from other populations. And in particular, back in 2012, some of the research and studies that had been done with IPS prior to that, it set them apart from that as well. Another distinguishing factor with our CalWORKs population is that with our CalWORKs participants, there's a secondary gain with participating in mental health treatment. Since they're being referred to the Department of Mental Health from the Department of Public Social Services, their CalWORKs mental health treatment becomes part of their contract with DPSS. And so mental health treatment is experienced for many of them as a requirement or a mandate in order for them to continue to receive their benefits. And so because of this, and because IPS falls under their umbrella of mental health services, there are various levels of motivation or willingness to be enrolled in IPS and to receive IPS services because of that factor, or to look for work. And even though we thought that back in 2012, CalWORKs participants would be more willing to participate in IPS, and that we'd be able to sell IPS pretty easily to them because they're being referred to help them work towards their employment goals. It did end up being one of the challenges of implementation for the CalWORKs population, because given the level of motivation being different from participant to participant, or a particular participant's perception of their vocational self-efficacy that some participants experience, as well as the tremendous amount of fear about stepping away from generational welfare in some cases and finding employment. And so this kind of goes along with what you were mentioning earlier, Chris, earlier today, in terms of the huge fear of losing all of their benefits. And so what I would say is one of the challenges for us has been less about client symptoms in most cases and more about their level of motivation and the fear behind what's going to happen to their benefits if they return to work. And then in terms of success, I would say despite some of these challenges that we've had, we have been very successful in implementing IPS. Prior to IPS implementation, our employment success rates were about 23% countywide. And over the years, we've been able to reach about 56% in terms of the outcomes for employment for clients enrolled in IPS. And so we're right up there with the IPS national average and with some of the research we all heard about earlier this morning from Dr. Bonds in terms of success rates. And then I would also add to that, one of our other bigger successes is that because we've been able to see this huge increase in employment rates over the years, it has led to DPSS providing additional funding and support of our collective mission of IPS. And at the end of the day, what that's helped with is that it's allowed us to staff more employment specialists countywide in our CalWORKs programs and be able to reach more clients.
That is fantastic. So it sounds like they opened up the purse strings a little bit more for the mental health allocation for you guys based on the success you've had. So that is great. All right, last but not least.
So I'd like to say that my answer is a little bit different because our program isn't up and running yet. CSH has been working on some pre-implementation planning with a couple supportive housing providers. And supportive housing really works well for individuals with really complex barriers and which also includes chronic homelessness, but comorbidities, complex health barriers that really prevent someone from thriving without housing. So that's the target population. And we've been working with 2 supportive housing providers to get them ready to launch their IPS programs within their supportive housing services offerings. This has been in the works since 2019, and it has been a journey and a very exciting journey where we are now about to stand up an IPS program. And I would say some of the challenges, and I think we're probably going to dig into a little bit deeper later in the conversation. But one of the things that I think we were really struggling with in our technical assistance is securing funding. We heard earlier that there's not one sole source of funding for IPS. And it really has been a challenge. We are so very, very fortunate that philanthropy has stepped up to the game. What I think we're doing here in Los Angeles is playing with directionality a little bit, where we're starting with the supportive housing providers, and which is why we're relying so much on philanthropy to help support these supportive housing, the IPS programs. Because we're wanting to build a case so that county can then buy in. So that's something, the funding early on is something that I think was a hurdle that we wanted to get over, and has been a journey. The successes, I would say, in that process of doing the pre-implementation and sort of doing the IPS drink the Kool-Aid Roadshow. We love IPS here, all the reasons why it's amazing and why it's so effective and why really the principles and practices, it matches so well with supportive housing tenants, is this buy-in that we were able to secure across the nonprofit, the supportive housing providers, and within their scope, and partnerships, they also have ACT teams and intensive case management teams, substance use disorder teams, right? And as we know, it's all multidisciplinary. So we were able to really garner the support of those cross-departmental staff members and leaders at the supportive housing executive level. And also really garnering partnership with Department of Rehabilitation, which is very new and nascent for this particular project, but we're so excited at the appetite of it.
That's awesome, Dara. Thank you for sharing that. I mean, that sort of is like the epitome of like a grassroots effort trying to, rally around this service and the uptake of the model. Yeah, I mean, you certainly have some heavyweights behind you, and CSH has definitely demonstrated success a little further south down in San Diego with programs there, and you've got all your housing programs who've got some experience with the model as well. So it's a little bit of the tail wagging the dog at this point, but yeah, you guys are gonna get there. We're super excited and glad that you're doing this awesome work. All right. Next question. So taking into account your specific specialty populations, what are some unique aspects you considered when planning and designing your IPS programs?
I can go first. So for our program, one of the things that was unique to our design was the participant flow and the communication and relationship we had with the Department of Public Social Services. And so when the system works at its best, a CalWORKs participant goes to the DPSS office, sits down with a gain services worker who screens them and refers them to the Department of Mental Health so that they can receive CalWORKs mental health treatment. Not only to address their mental health barriers, but also to link them to our IPS services as well. And so one of the things that has been really great is that we've had a steady flow of participants referred over to us from DPSS over the years, which has helped with engagement rates in IPS. Another consideration for us in planning to implement IPS was using a top-down approach in working with our CalWORKs providers in order to get that buy-in and the commitment to providing IPS services at the agency level, because this is something that was completely new within LA County Department of Mental Health. And so we really needed the directors and program managers to have that commitment and adhere to the IPS model and ensure that we were working with the agencies to protect the employment specialist role as we were implementing the IPS model. That is pre-IPS, our CalWORKs providers had case management staff that were part of their treatment teams. And so what was unique about us planning and designing to implement IPS early on was that we had to convert case managers to employment specialists. And this was pretty advantageous actually to our program because the case managers were already embedded in a multidisciplinary team. So it kind of made for a natural integration of services using a multidisciplinary team approach. But our early plan included training and transitioning case management staff to employment staff to ensure that, again, the employment specialist role was protected and adhered to. So we had to use that top-down approach to ensure that that occurred.
Awesome, thank you.
I can go next. I think with planning and implementation, we the core tenet of IPS is that anyone who wants to work can work. And I think that there's no exception and supportive housing is really no exception to that. Supportive housing in and of itself is an institution. And there are tenants who often feel stuck in supportive housing. And so the goal is to, with bringing IPS in, is to really help support if someone is wanting to gain independence and move on from supportive housing into affordable housing and into then fair market rate housing. We want jobs to be an avenue that's accessible. So we took the fact that the case management model for supportive housing is so integrated, and the fact that IPS is also such an integrated model, to really sort of leverage and play with the staffing structure of what an IPS employment specialist can look like in a supportive housing setting. So using the flexibility and the innovation of supportive housing case managers who meet the needs of the tenants, looking at that integrated supportive housing setting help to feed in and sort of reinforce that an IPS employment specialist would be a really good match in sort of bolstering that team approach. Sort of doubling down on that in a way is the fact that the supportive housing provider, who is now working so hard to stand up their IPS program, they actually have a really robust peer advocate staffing model. And those peer advocates are now being trained, similar to what Tatevik, you just said, of, sort of switching the roles. Some of those peer advocates are now being trained to be employment specialists to serve the residents who are enrolling in IPS.
And then in terms of the challenges faced in our program, so like I was saying before, that transitional time requires additional supports for the educational services. So it's been kind of a challenge figuring out how to braid funding together to actually support the young people through that process. Because like I was saying, the new TAY fidelity scale through the IPS folks is really highlighting the combination of those two supports. So that's been interesting. And thankfully, with the help of Teresa and Chris, we've been able to incorporate Medi-Cal funding into the services that we're providing, as well as braiding together a couple of other grant sources within the city. So that's allowed us to provide more holistic in the sense of like education and employment supports. Outside of that, I think another big thing that's come up is that because of just the nature of this age range, oftentimes the mental health services that the young people are receiving end before we are done working with them, before they have reached their employment goals, because they turn 18 and then suddenly they don't qualify for pediatric services anymore, or they graduate high school and suddenly they've lost their entire mental health team. And so historically, that's been a real challenge for us as an agency to continue to provide IPS services without that accompanying mental health team. So thankfully, in the last couple of years, San Francisco DPH has put together a TAY linkage service. So that's made it much more streamlined for young people to be connected to the adult services for mental health within the city, if that's something that they're still seeking. And so that's allowed us to provide more continuity of care within the mental health piece, so that we can continue to support them with the employment piece alongside. And so I think those have been kind of the main challenges and ways that we've gone around them.
Yeah, that's fantastic, Christine. I mean, just identifying those system gaps, and using IPS and the IPS framework sort of as justification to ask, to advocate for systems change. Like, again, one of the primary practice principles is, the time unlimited support aspect of it all, with the caveat, of course, right, being that, we'll provide this support so long as you remain eligible for services. But when folks turn 18 or, Tatevik, if somebody makes just enough money to, exceed, the gainful activity, people, folks just, fall off a cliff. So, being proactive, thinking about that, seeing how we can make, not necessarily have IPS bend to the system, but have the system maybe bend a little bit toward IPS. So that's fantastic. And, I just wanted to comment on, what both Dara and Tatevik were saying as far as, programs who are interested in uptake, of the service. And it's always about, the money, right? Where's the money going to come from? If we don't have great, folks, big donators, or, there's just not enough, in the existing budget for that, internally, how can we think a little bit outside the box? And what you guys kind of commented on is like, let's look at our existing, an approach is to look at our existing staffing structure and see like, okay, what roles that we already have, align closely with, what an employment specialist does, what an employment specialist stands for. And let's see if we can't leverage those existing roles and just, kind of morph them, into employment specialists. And it's certainly not easy, especially, Tatevik, when you're talking about, 40 plus existing programs, already, and we're coming in and we're saying, hey, we want to implement some change, with anything, with change, not everybody's on board with that. We typically have, our early adopters, who are open to the idea and are curious and are willing to try new things out. We've got our fed sitters, and then we definitely have, our folks who are the naysayers. So maybe Tatevik, I know this is going way back, and I know you weren't there in 2012, or were you? But maybe you can talk just a little bit about the process of, implementing IPS and getting these, these 40 different clinics to sort of, drink the Kool-Aid, as Dara says. Any like best practices, tips, tricks around, enacting that level of system change. I mean, because, as you guys know, the way we did it in Alameda County for our CalWORKs program is we totally redesigned, the program entirely. We rebid the contract out and made sure that IPS was a core service there. But you guys were a little bit different.
I'm so sorry, Chris. I missed your whole question because my internet.
Oh, darn. Okay. And you're freezing up on us. Okay. Can you hear me now?
Yes.
Okay. So I was saying, I don't think you were around back in 2012, right? When
I wasn't.
Everything got converted over. I was just talking about, or just, sort of reflecting on how difficult it can be to implement, systems change, especially in the big, DMH CalWORKs system. Like what are some tips, some tricks to uptake a new service, get somebody to, to take on new things, right? We certainly have, the small group of people who are curious and open to taking on new things. The folks that are just going to kind of sit on the sidelines and wait and see how everything pans out. And, we definitely have the folks that are just absolutely against anything new. So maybe just, if you've got some reflection on, for our audience, for folks who don't have, big donors to bring on new staff, or we just don't have, a space in the existing budget to create employment specialist positions, just maybe walk us through that evolution.
Sure.
From what
So one of the things I would say is, even though as I had mentioned, it was advantageous for us to already have case managers in our CalWORKs treatment teams, and there was that natural integration with the treatment team approach, it was also one of our challenges. So one of the things that I would mention as a challenge in being able to convert case managers to an employment specialist role is that, case managers were doing a specific type of work on the treatment team. And you could have a staff who's a really great case manager, but that doesn't necessarily mean that they're going to be a good or a great employment specialist, or they might be a great employment specialist, but it might not be something that they necessarily want to do. because it's a very unique role and it does require a very specific skill set. So part of our challenge was that we had to make sure that we had the right staff in place and also provided sufficient training and ongoing support to our providers to ensure that they were able to hire staff to kind of fit the role that we needed with the employment specialists. So that was something that, we had to work with our providers on. And then just in general, in terms of implementation, what I would say is, you're right, I wasn't around back in 2012, but with CalWORKs Programs Administration, our leadership, and in particular, Dr. Armstrong, who is our CalWORKs Program Manager, he and the team recognized things as barriers arose. When they recognized barriers as they arose, they would quickly implement strategies or come up with a new approach to address whatever barriers arose. So we have worked very closely with our providers. We've tried to be as flexible as possible because we do have a very large network of providers. So we had to create opportunities for them to be able to communicate with us and tell us what's working, tell us what's not working, work with them and partner with them to problem solve, identify training needs for them and their staff, and just, do what we could together to make IPS work because we did really believe in the efficacy of the model.
Thank you. And then Dara, you mentioned, looking at the existing pool of peers as a resource, as sort of like a natural fit for this type of work. I know, in our experience here in Alameda County, we definitely would not be where we're at today without the support and without the voice, of peer consumers, within our system of care that just, saw this service, rallied behind it, and said, yes, this is something, that we want. The whole, nothing about us without us, is very much in effect here. So thank you for bringing that up as well. So for agencies that are, thinking of, of building that grassroots network and forming, your allies, we definitely, always have to include, our peers in that conversation as well. All right, so we touched on it a little bit here, but the third question is, and maybe we can expand a little bit more, think about some other examples. Since launch of your IPS programs, what have been some of the biggest sustainability and implementation challenges you've had to address?
I'll go ahead and start. So I already mentioned a minute ago the challenges that were staff related in terms of the case managers and the uniqueness of the employment specialist role. One thing I would add in terms of sustainability challenges is the need for training. Because we had a very large network of providers that we needed to implement IPS in, we took a very calculated and a very gradual approach to implementing IPS countywide. And so to make it sustainable, we rolled out our training in a series of 3 cohorts. And this approach helped us because it allowed us to take a minute, analyze what's working, analyze what's not working, think about what ways we needed to pivot and make changes for the next cohort that we had to train, and then identify whether or not there were any opportunities to enhance the types of training or our perspective as we were rolling out the IPS program from cohort to cohort.
Thank you, Tatevik. Can you, okay, and we're talking specifically about the clinical teams, correct?
Yes.
Okay. Can you talk to us a little bit? Okay, so we're similar up here in Alameda County, where we have an MOU and an agreement with our county social services department, right? These are, technically speaking, these are for the CalWORKs and TANF population. They are social services clients who have behavioral health or mental health challenges and barriers that are preventing them from going back to work. And it sounds like much like our agreement, our system up here, folks are first screened at social services and then referred to behavioral health. what sort of, buy-in or training or conversations are you guys having with social services down there in LA in order to sort of just raise the awareness about, mental health, right? And that in general, and the stigma around that, but just like, hey, look, we've got this awesome service here that is really intensive and can, really do a lot of good for folks who've got some mental health challenges.
Early on, we ourselves worked with the Department of Public Social Services Administration team, and it also encouraged our providers to do some outreach at local GAIN offices to provide information about their mental health services, including IPS, so that they could share with the GAIN workers what types of services were available through IPS and how that would assist participants in getting employed and becoming self-sufficient. So that was really helpful in terms of helping with that flow of participants getting referred over to us. And then if I could, I would like to also add on the clinical team as well. One of the other challenges I would say in enrolling in IPS came along with clinicians' perceptions early on when we first rolled IPS out in terms of how helpful IPS would be for a particular type of client. And so, for example, sometimes clinicians would subjectively believe that some clients weren't really ready to work, or that returning to work could harm or it could exacerbate their symptoms. And so we did do a significant amount of training with our providers as well around zero exclusion. So we conducted employment specialist trainings, we conducted clinician-specific trainings. And so for our clinicians, we specifically designed trainings to help them think about some of their beliefs and really dig into some of the factors or the barriers that were preventing them from referring clients to IPS to help with those engagement rates. And we had a lot of different types of trainings. We tried to approach it from multiple perspectives. So we had IPS trainings, we had quarterly meetings with our providers. We also did item-based trainings and technical assistance visits throughout the years. And we continue to do those things on an ongoing basis because of staff turnover and, just to make sure that we're helping providers adhere to the model as closely as possible.
Great, thank you. The zero exclusion thing, wow, it's a universal struggle, but nothing that we can't address, right? And I think, over time, right, as folks see the results and see the outcomes, we slowly pull people off the fence. All right, so again, the question is, so since launch of IPS programs, what have been some of the biggest sustainability and implementation challenges you've had to address?
So I wanted to jump on what you were saying in that we've had similar issues. I mean, I think like you were saying, Chris, it's kind of universal, but we've had similar challenges, just kind of reinforcing the concept of zero exclusion, especially because the young people that we work with are transitioning into adulthood. And so oftentimes the clinicians who've been working with them have been working with them since they were a lot smaller. And so they're still in this mindset of being like, okay, well then maybe a volunteer program would be appropriate, or maybe a like an after school thing where you get a stipend would be great. And so I think it's been a really interesting challenge to retrain the clinicians to think, okay, well, that's great if that's what the client wants. However, if the client is saying, I want a job, an after school program where they pay a stipend is not a job. And so if they say that they want a job, then let's support them in reaching that goal. So it's been interesting. I think part of what we've done as an agency to kind of bring that message home is to have every staff member watch a training video on the IPS model when they're hired. And so it's like a 45-minute informational thing that we created in-house that specifically talks about the concerns that they might have, the things that we've seen, as well as the successes that we've seen within our program for youth who may not have had, for others may not have had that expectation of them, but that was their goal and we supported them in reaching that goal. and wonderful things have happened as a result. We could get into success stories, but I don't think this is the place. But regardless, I think that's that sort of very specific approach has been really helpful within our agency to kind of remind clinicians of the fact that a referral is always appropriate if the client wants to work, and that's the only requirement.
Awesome, thank you for that, Christine.
So we are in the throes of beginning our implementation. So I know my colleagues over at Skid Row Housing Trust who are listening in are probably taking notes on all the things that Christine and Tatevik are talking about. We have relied so heavily and are so grateful to Chris and Teresa in Alameda County for their guidance in building out these IPS programs. We're also really closely connected with the folks over at now Columbia University, formerly over at Westat and the IPS Employment Center. I think it's the Research Foundation for Mental Hygiene is that's it. That's the new research arm. The implementation challenges, I think, I had mentioned before, supportive housing is deeply affordable housing and is coupled with subsidy. So we talked and touched on the benefits cliffs. I think in our implementation, we're anticipating the benefits cliffs and sort of the disincentives that exist, and like the murkiness of the transition from benefits to employment, and really how that will affect the tenants who are wanting to work but are avoiding it because they don't want the subsidies, their health insurance, their monthly benefits, and their housing subsidy to be swiped out from under them. So we're really, I think as part of the implementation, we're making sure and really encouraging the staff who are being employed at Skid Row Housing Trust, who's the supportive housing provider who's standing up this IPS program in Los Angeles, to attend benefits counseling through Cornell University. Since LA County, we don't have terribly too many benefits counselors. That in and of itself is also problematic because that benefits counseling is really focused on federal benefits, and the nuances are on the local benefits, and just sort of, what are the limits to each of your benefits that would cause any and trigger any change in your housing subsidy or your monthly cash aid, things like that. Those are, the ones that are potentially county driven. So those, I think, are implementation challenges that we are not naive to and are really thinking through thoughtfully and leaning on experts and creative ways to sort of get ahead of it, so that it doesn't become, so that work isn't a disincentive.
That makes total sense. Yes, just always being aware and cognizant of what those unintended consequences might be, and specifically for these very nuanced local programs. It's tough, right? We're not experts in those fields, in those programs, so we really do gotta find out who is, and bring them into the conversation as well. All right, next question. Achieving high fidelity standards is often an iterative process. What kind of creative approaches regarding service delivery, staffing, or program structure have you all taken in order to reach IPS fidelity standards? So again, more in the spirit of, not how can we bend IPS towards us, but how are we bending more in reconfiguring things so that we can meet the standards as they were designed, especially for your populations that aren't necessarily, some of the things don't exactly quite fit with IPS fidelity as it stands.
I can start with this one. I think I'm also noticing that in the Q&A, Danny, you've had a couple questions, and this falls in line with what you were asking most recently. So for job retention services, once they're closed in DOR, so the once they've been employed for 3 months, they can close successfully in DOR, and then the funding through DOR stops. Thankfully, we've been able to braid our funding, so we're able to provide continued follow-along supports with either Medi-Cal funding or DCYF funding. DCYF stands for Department of Children, Youth, and Families, which is a San Francisco specific fund. So those are the ways that we've been able to pay for follow along supports, which is one of the ways that we've been able to kind of figure out how to be more aligned with the IPS fidelity. Another thing that we've done is we've had people on staff get trained as fidelity reviewers. And so one of the things that's been really wonderful about that is, so one of the people that's been trained is our QA, no, quality assurance, yes, QA. Question and answer is what I was thinking. QA person has been, who is also on the executive team, has been trained in the fidelity, how to be a fidelity reviewer, which has been lovely because now she has so much more intimate knowledge of the model that allows her to not only kind of keep us in check on it at times, but also to keep the rest of the staff in check in terms of the other programs where they refer. So she's able to kind of correct any sort of swaying that happens at the executive level within the agency or within the team of psychotherapists that we work with as well. So sometimes there's a bit of drift, and she's able to course correct, which is lovely. And then the other piece of that is that it costs money to have a fidelity review regularly. So you're supposed to have one every year once you reach good fidelity. And so what this allows us to do is to partner up with fidelity reviewers in other parts of the state and then kind of like swap services. Which is cost effective and a great way to get to know what other people within the state are doing in terms of implementation.
Those are all awesome points. Thank you, Christine.
I'll go next. So I would bring up on our end, I had mentioned earlier that we provided various types of training to approach some of the challenges that we had. Something that I hadn't mentioned earlier regarding trainings is that early on when we implemented IPS, we also recruited a countywide job development specialist to train us and our providers on job development. Which now our team does internally, but in the beginning of the implementation of IPS, that was one of the creative approaches that we took to really build and enhance the job development skills of the employment specialists in our programs. And to kind of go along with what Christine was mentioning, we also do fidelity reviews, but initially we didn't conduct the fidelity reviews ourselves. In the first couple of years, we actually had experts from Dartmouth conduct the initial rounds of fidelity reviews in partnership with us. And so that was a really good approach too, and helped us to really adhere to the IPS model fully. And then finally, what I would say is just, we listened as much as possible to our providers and tried to use creative approaches based on what their experiences were. And a lot of that had to do with geographical types of challenges that would come up. So an example of this is with one of the service areas in Los Angeles County, which is Antelope Valley. It's a very isolated geographical part of LA County. So we only have 3 CalWORKs providers in that area. And one of them was able to achieve exemplary fidelity standards. And one of the great things, even though they're very isolated up there, is that they were able to partner very closely and work more closely with the Department of Rehabilitation in that area because they're so isolated and it's a smaller area. And that was something that we celebrated, and it was unique to their experience. And so that was another thing I would say that was unique about our CalWORKs providers' experiences.
I would say, again, we're just implementing this IPS program with Skid Row Housing Trust in Los Angeles. So sort of in the fidelity training and review piece, we are really similar to DMH. We're partnering really closely with Westat Research Foundation. What is it? The Research Foundation for Mental Hygiene to conduct training and evaluation to really sort of help us get to fidelity, but make sure that we're implementing this in a way, especially because it's a new population that hasn't really been litmus tested before. So we have this opportunity to sort of legitimize and underscore what IPS can do with supportive housing tenants or residents. So we're leaning on them and bringing them into the fold to help us with training and evaluation. We're also on sort of the staffing bucket of the fidelity scale. You know, we did really in-depth budget analysis with the providers that we did this technical assistance with, and really looking and leveraging intensive case management services and the partnerships with federally qualified health centers. A lot of supportive housing providers have either they have clinics on site that are federally qualified health centers, or they have really close partnerships if they're offsite. So seeing what sort of leveraging opportunities would be able to help specifically with the staffing structure, making sure and supporting the housing staff to add on to an employment specialist so that we really make sure that there's no job creep. We really want to prevent that and keep the employment specialist wearing the employment hat and take that load off of the housing case managers.
Awesome, thank you. Okay, next question. What level of success have you achieved in your programs thus far? Time to brag on yourselves.
I'll start this one. So I would mention two things. One of them is that we have 2 CalWORKs providers that have achieved and are maintaining exemplary fidelity status, which is just really amazing. And it's something that we think is really important. Something that we think is always important for our network of providers to do is to share amongst themselves whatever challenges they experience, whatever successes they experience with one another. And so most of our providers have achieved good fidelity, and the 2 that have achieved exemplary fidelity have been able to highlight over the years some of the practices and creative approaches that they themselves have taken to be able to maintain that status. And it's been a great way for us to share with our network of providers and kind of bring them up to speed about what's working well and how they can kind of think about either using the same type of creative process or similar types of creative processes within their own agencies to help them adhere to the model and continue to enhance their services. And then the second piece I would say is, as I had mentioned earlier, we've been able to double our employment rates since the implementation of IPS, which means more clients are getting jobs and working towards sufficiency, which is the goal at the end of the day.
Thank you, Tatevik. Go ahead, Dara.
And so I was really excited. I generally don't look at these numbers in this way, but in preparation for this panel, I pulled our numbers from the last year, and of our 85 clients, at least 56 of them had at least one job. And so that's 65%, which is pretty exciting. And so I'd say that's quite a success. Outside of that, I think more globally, what's been really wonderful is through the advocacy of Chris and Teresa and another group of just amazing folks. They've been able to change the DOR contracts to account for the IPS model.
Right.
And so that's been wonderful for us in that the way the DOR contracts were constructed originally, they weren't really tailored towards the IPS approach. And now it's more closely aligned with the sorts of markers that you would expect in an IPS model, which has been really validating. And it's great when the funding sources align with the model that you're utilizing.
I would say for us, we're starting to see, in the supportive housing providers, we're starting to see the value of adding in a specific workforce development program into their supportive housing services offerings. We are launching this pilot in the beginning of 2023, and CSH is also starting to work with more supportive housing providers to do the same sort of implementation or pre-implementation, getting them ready to stand up their program, new IPS programs. So really sort of like, proliferating employment within supportive housing, which I think has largely been sort of cast aside in years past, decades past, really. Especially because of the really unique and high barriers that supportive housing residents have. I think similar to what you all were talking about earlier, the staff may be sort of gatekeeping and not thinking that clients are ready or participants are ready to work. This is sort of a paradigm shift, which I see as a really big success.
Awesome, thank you, Dara. Well, in the interest of time, we have just a couple minutes left. Danny did have one more question here, and that was around, what types of organized marketing do employees, I guess, of your program do? So maybe just in a nutshell, if people on missed the IPS 101, maybe just really quickly, when your folks are out doing job development, what is that about? I think that's what Danny means as far as organized marketing.
Yeah, so I guess I could speak to this. We speak with our clients individually and they identify, hey, I'd like to work at a dog shop and it needs to be within 5 miles of my house and I only want to work on Saturdays. And so then we go out into the community, meet with employers that would fit within that category, talk to them about what they're looking for in employees, talk to them a little bit about the ethos of their business and which roles they have difficulties filling, what shifts they have difficulties filling, those types of things, and really just get to know them and their needs, and then develop a relationship in that way. And from that point, we're able to eventually get to the point of connecting them with the client if there is a match between that business's needs and the client's preferences and skills.
I think that was it in a nutshell. And then one other question just crept in, and Dara, you were the one who mentioned this. You mentioned job creep, right? Scope creep. Can you just kind of talk a little bit about that and, making sure we honor and protect the role, everyone's role, really, in a multidisciplinary team?
Sure. I think with case management, especially in a supportive housing setting, I think it's an all hands on deck and do whatever it takes for as long as it takes, is sort of that is the mentality. And so case managers end up wearing so many different hats. And to keep to the IPS fidelity model, an employment specialist is really supposed to focus on employment specific tasks and not start talking about housing or start talking about substance use supports, but rather maybe refer them out to those, refer them back to the case manager instead of focusing on their employment. So that is what I meant by job creep. It's really important in order to stick to fidelity, to have that sort of one person ringing the job bell and staying on jobs for their main focus of their day-to-day work with clients.
Yep, I think that was it. And one of the founders of the model succinctly said that without team integration, without being part of a multidisciplinary team, you really can't claim to be doing IPS, just because, you know, the role and the job of the employment specialist is so narrowly focused on just the employment piece, just the education piece. Once, you know, they get pulled in other directions, that's when the drift occurs. And we really want to respect everyone's roles, much like, you know, we respect the doctor and the psychiatrist role. We're not asking them to go run around and deal with housing, you know, things. They're the med prescribers, and that's what they do. So we want to afford the same respect to everybody on the team. So thank you guys so much for spending this time to sit with us and talk about the unique challenges and successes for your specialty populations. I'm sure it was a huge help to a lot of folks at this point. So thank you very much.